If you have questions during this, you can indicate to me in some way that you want to say something. And if you want to wait till the end, that's fine too. We should have some time for discussion. So as Amy said, I was asked to talk today particularly about how we're shifting to the priorities for phase 2 of the support unit funding here in the province. And I will start by just giving an idea of what was involved overall. So I'm sure most of you already know that the CIHR has a strategy for patient-oriented research. And under that, they have commissioned various jurisdictional support units, of which we're one, and different networks focused on specific health issues, as well as primary care. And then there are entities that are aimed at improving the research landscape, such as the data platform, the training entity, and so on. The funding is provided in part by the CIHR, but it has to be matched by somewhere else. And in our case, it's by the provincial government. In other provinces, there might be other sources of funding. The SPOR entities began work at different times, so you will find that not every support unit, for example, is at the same stage of their phase 2 work as we are. And we expect that we will continue to do this for about the next 5 or 7 years, depending on how the funding lasts and the mandate exists. So the principles of the SPOR overall were to have patients engaged as partners in health research. And when they say patients, they don't mean people with sickness. They mean people with lived experience or some understanding of health and health care, and to bring their particular perspectives to enrich the ability to do and understand and disseminate research results. Moving results into practice actually has proven to be a problem over the years, with it often taking up to 20 years, for example, to get results from influential trials into widespread use. There's also a wish to enhance capacity through training and education, and that would focus in part on how to effectively engage people as partners in your work, but also educating the public on the methods of health research and how to consume or interpret the output of research. There's a wish to facilitate and fund research that is addressing key health needs and challenges. And in this second phase in particular, there's been an extra emphasis placed on equity, diversity, and inclusiveness, meaning that there should be a room for everybody in this process. And a value lens is also applied. So in other words, what you're doing is hoped to achieve better outcomes for the inputs or costs, for example, that you spend on healthcare and other things. There's a need to integrate knowledge users and decision makers into the research process when you're looking at applied health research. So different from a laboratory where you may be doing basic medical science and it's inquiry or scientific understanding maybe that's pushing your particular agenda. In the applied realm, we really want to try and respond to real world needs and priorities. And to identify those, we have to work with the public and also with, say, decision makers at departments of health and other areas within the system to say, this is where we should focus. And in addition, once you have these people integrated from the beginning, they're able to better understand the nature of the results of your research and hopefully better translate them into new policy or new practice options. So here's the sort of model that was put out for SPOR phase 1, which is finished here now. And at the center, you can see patient engagement. So everything was meant to focus on that to begin with. And then there were 6 key areas, which went from applied health research through developing data platforms and services, providing consultation, enhancing clinical trials, training and capacity development, and innovative methods. So those things are all still important, but the focus has shifted a little bit in phase 2. So here's where we ended our phase 1 in terms of patient engagement. We had an established strategy. We've got a very active and effective patient advisory council, and we have patients engaged throughout our work, both in governing the activities of the unit and also in the various types of research outputs that we are involved with. In terms of training and research in patient education, we have been engaged in this from the beginning. We have an academic patient engagement lead, and we have other patient partners involved with this work. They have been effective in training researchers, for example, through a university-based course for graduate students on patient engagement, but also through the various types of teachings that were promoted by the CIHR and which we have disseminated in our province. And we're also connected to a new entity called the National Training Entity, which was developed to more broadly focus on the SPOR aims and to enhance training across the country in all aspects of this work. We have, of course, been involved in learning about the best way to do patient engagement and have been publishing some papers to that effect based on the results of our work. We have funded other patient-oriented researchers who have been doing studies with patient engagement. They may be targeting various types of health conditions within our province. They may be led by healthcare providers, in some cases, people working in the front lines. We've had Indigenous community engagement for a patient-oriented research project, which was focused on, for example, culturally appropriate end-of-life care in an Innu community in Labrador. And ultimately, we're working towards developing a culture of patient engagement with all our partners. And it's been the case that regional health authorities, government, etc., have all seen the value of engaging the public and patients as part of their deliberative processes. In terms of capacity development, we have an established training and learning environment. This webinar series is part of what we were doing before as well. And we engaged with our learner community to try and understand their needs and to understand the best ways to reach them. So we've had a variety of in-person events, town halls for the public, these types of webinars, and the content varies quite a bit depending on what people need, from teaching about research methods, teaching about patient engagement, understanding the outputs of some of the patient-oriented projects done in the province, etc. We've also supported learners through our master's and PhD programs. So if students are interested in doing patient-oriented research as part of their graduate program, they can apply to us for student support. We have some involvement with the new national training entity that has to be beefed up a bit, I think. They're getting their feet on the ground now, and I think we'll probably see more engagement with them in the future. And we've worked extensively with our policymakers and decision makers to enhance their engagement of patients and knowledge uptake. And I'll talk a little bit about how we're doing that in phase 2 in a while. In terms of data, we have been largely working with our provincial data centre, the Newfoundland and Labrador Centre for Health Information, which is undergoing transformation at the moment. So when we started phase 1, they were a Crown corporation at somewhat arm's length from the government, and we could apply to them for data sets to be developed and sent to us for analysis. These were largely health administrative data sets, and we could use them for our research. Now they've been folded into the Department of Health with an emerging kind of governance model, and they have developed a data lab whereby people who wish to analyze and work with their data are given privileged access to aspects of the data system and can do their analysis within their environment and then just export the results for dissemination outside. We have collaborated with the Centre to coordinate our roles in messaging various groups. For example, we produce practice reports for clinicians to feedback on their usage of healthcare resources. We've provided reports to the long-term care sector on quality of care within individual long-term care homes and so on. And our intent is to develop new data sources that can be integrated into the health record. One example of that would be the genomic data. So we have links partly through our data center that Amy mentioned I'm the lead for as well, to our genomics lab where we can do sequencing. And the intent is to, for example, find actionable variants within sequences that are being done for other reasons that might influence people's usage of various types of drug therapies. The hope is that that type of information can be put out through our health information system to providers, both pharmacists and physicians, for example, to influence their choice of medications and to avoid potentially toxic or non-effective drug use. We're also engaged with the Centre for Health Information to partner with the SPOR National Data Platform to facilitate interjurisdictional studies. So this would be important in doing comparative analyses across the country, or maybe doing national comparison with other jurisdictions. And up to this point, it's been difficult for people, say in Ontario or Quebec, to access data, at least rich data, patient-specific data from other provinces, to marry it with their own and come up with some kind of results. So this Canadian data platform aims to enhance that, and we're contributing to that. In terms of clinical trials, we have partnered on some, mostly the innovative clinical trials funded by CIHR through the SPOR platform. Some of these were examples were trials aimed at evaluating various interventions aimed at choosing wisely targets, trying to reduce low-value care, and also the SurgCon trial, which is aimed at enhancing flow through busy emergency departments. In terms of methods development, our main contributions have been in patient engagement, and we have consulted and provided research support to many, many investigators and groups here locally, and to a lesser extent across the country. In terms of applied health research, we jumped on this one to begin with. So many support units are really support units. They don't necessarily do research themselves, but our province is fairly small, and the group of engaged practitioners and patients were the same ones who were interested in supporting research, were also interested in doing it. So we developed two programs. One is Choosing Wisely NL, which is a partner, a regional affiliate with Choosing Wisely Canada. And the intent there was to work on implementing guidelines and recommendations produced centrally to avoid unnecessary or low-value care. An example there would be, say, the overuse of antibiotics or the careful use of blood products, etc. But our other program, which is a main focus going forward, is Quality of Care NL. So this was formed to really look at trying to get the right intervention to the right person at the right time. So it goes beyond eliminating low-value care to trying to enhance the use of effective interventions and trying to improve system performance. So there we've done things, for example, around care pathways for stroke and brain injury. We've developed electronic ordering options that use some of the electronic infrastructure in the province to automate appointment setting and triage for things like vascular studies, looking at arterial flow to the legs or to the head. And that has led to major improvements in the efficiency of that particular service. We have a flagship publication that we use for knowledge mobilization known as Practice Points. This is up to about 10 volumes now. They're produced approximately 2 per year, and they've grown from about 6 or 8 one-page reports on activities up to hundreds of pages now. And the focus is on many aspects of the healthcare system and performance in the province, but also looking at international comparisons and other types of comparisons, hopefully to inform decisions around future development of the system and future improvements in health in the province. To achieve that, Quality of Care program actually engaged with the Department of Health and other partners to develop a thing called the Health Accord NL, which has a 10-year goal to transform the health of the province. And I'll spend a little more time on that as a component of our phase 2 work. So this is kind of the approach we took with Quality of Care. We would identify problems either ourselves, or people would come to us saying we've got an issue with, an example being usage of medications in neonates or allergy testing or something like that. We would then try to understand the problem better using our data sources, develop a study to either better understand the issue, or if we already did, to implement some kind of change. Once the change implementation was designed, we then went on to reevaluate to see whether the change had been effective, and the results were generally disseminated through practice points and other means. We've used a variety of knowledge translation techniques for our work, including development of arts-based knowledge mobilization tools like the cut of it, which is a play, initially now a video, that describes the results of one of the studies evaluating women's journeys with breast cancer. We've also had artwork developed to demonstrate the results of the Indigenous project that I mentioned earlier, done with the Innu group in Labrador. Some of the work we've done, partly with a choosing wisely focus, was aimed at frontline clinicians, often family doctors, and we would identify maybe a pattern of over-frequent use of certain types of testing. This included kidney function testing, cholesterol levels, thyroid function testing, etc. And in those instances, we developed education materials for the providers, which we distributed to them, both electronically and often in person. We also added on various types of audit and feedback mechanisms, so people would be given information about their use of particular test patterns, for example, in comparison to peers. And they might have an academic detailing whereby somebody would visit their practice site and talk about the issue and explore ways to change what they were doing to reduce unnecessary care. We have other means apart from practice points to disseminate results. The little visuals down there are all on our website. Anybody can access these at any point. But annually, we've also had interactions with the public, and there have been two kind of ways to do that. One is the Share Summit, we call it now, which is focused in part on researchers, policymakers, decision makers, and various partners, but is open to the public. And then we've had more specifically public focused events where we would invite people to come in and see the results of various types of projects presented in ways that might be family friendly, for example. So these are the components now of phase 2. They're a little bit different, but overlapping with what we had been asked to attend to in phase 1. So you can see that there's still a focus on data platforms and services. There's still a major component of patient engagement and capacity development. And what's really a bit new in this is that one of our goals is to promote the development of a learning health system. And I'll spend a few minutes on that in a sec. We've expanded that a bit because through the Health Accord work, we've understood the importance of social determinants of health and upstream factors, as we call it, that is, things that happen outside of the traditional healthcare system that largely influence health. And that could be things like your economic well-being, your community resources, your food security, etc. So those aspects of the social care system are also part of our lens. And I don't think there's any reason why you couldn't have a learning social system as much as you can have a learning health system. We had to change our governance structure a little bit to match the needs of this new phase 2. So we still have an oversight committee that includes funding partners and influential decision makers and patients here. There's an executive committee, which is a smaller group that kind of does the day-to-day work. And then we have core component committees that are focused on each of those core components outlined for phase 2. In addition to those, we have advisory committees, which include, of course, our Patient Advisory Council. We also have Indigenous consultations, and we have so-called clinical and social leads. These are people who volunteered to help us with our activities, providing their own expertise, for example, interpreting health data and helping us in producing appropriate messages for practice points. In terms of each of the core components, then, the data platform will build on what we have established at NILCHI. We will help people to access those data. So if they're not familiar with using health administrative data, we will guide them through that. We are important in making linkages between data sets. We might ask questions that have NILCHI think in a new way. We process data requests and hope to keep that transparent and timely. We will use data sharing agreements where necessary to ensure that there is appropriate control of data. And we do respond to data requests, although we may have to go to our partners to actually access the data. Members of the support unit are actively engaged with the Canadian data platform and other support units to either support multi-jurisdictional research, which is partly now done through the SPOR Support Unit Council, but also we work individually with other networks, etc., to try and look at multi-jurisdictional options. In terms of capacity development, we are aligned with the SPOR capacity development framework, and we are engaged in advancing the science of patient engagement. We provide local training and we provide scholarships to students. We engage a wider spectrum of stakeholders, so we're always looking to try and find members of the public who are either not aware of what we do or maybe interested if they were more appropriately educated. And we will, as mentioned, work with the SPOR training entity. We're hoping to build capacity for patient engagement by modeling that and showing how patients can be influential and helpful at all levels of governance and research. With the patient engagement itself, we're again aligned with the SPOR patient engagement framework, and we do have, I think, meaningful engagement on our governance structures and research projects with many patient partners. Now, the learning health system, which I mentioned was one of the newer aspects of phase 2, is intended to generate new knowledge and refine and deliver best practices for continuous improvement within health systems. And the aspects there would range from priority setting to engagement of the public and frontline staff, the synthesis of knowledge, the use of things like implementation science to spread and scale effective interventions, the evaluation of various programs, and translation of knowledge generally. And to achieve this, there's a whole load of core components required for a learning health system. So what we're doing at the moment is trying to understand what currently exists within the current regional health authorities that are about to merge, and then to demonstrate to the leadership the gaps that exist and the opportunities for improvement in further developing a learning health system. This system would undertake cycles, which would really start with an issue, understand that issue better, start to look at potential improvements or solutions, then implement those maybe in a restricted manner first, evaluate those, and then spread and scale. Now, it's very similar to quality improvement, plan, do, check, act cycles that people might be familiar from before. There are some additional requirements in phase 2 apart from the things that each unit has been asked to do from the beginning. One is to work across SPOR entities. So there's many different networks and support units that have been working effectively on their own, but the CIHR would see some potential synergy and some value to trying to bring these together to ensure a more focused attention to the aims and outcomes of the SPOR process in general. And to do this, they have asked that we provide at least 50% of our annual CIHR funding to support the needs of other SPOR-funded entities. This is generally through in-kind donation of staff time and resources. It's not, generally speaking, cash. The plan would be to facilitate services, and I know there are people on our webinar today who may be able to talk about that, and to be transparent in how we use our funding. And the governance structure, they ask that it be robust, diverse, and sustainable, and that it be in place by March last year. Well, of course, it is in place. And the ultimate goal is to have a sustainability plan, because the funding for SPOR is meant to finish after this phase 2, and to try to ensure that the types of gains that are made with the SPOR encouragement continue. We need to have embedded within the system, if you like, a culture of patient engagement and hopefully learning health systems that are capable of sustaining future improvements. So this is just a graphic showing a learning health system in operation here. You can see the external environment is the yellow or beigey bit towards the right there, which is showing people in the communities interacting through that large broad arrow with the health system, and the health system in turn interacting with the public, both as a source of priority setting and as a means or a place to disseminate new knowledge. Within the system, you can see the cycle going around in a circle and going from designing to implementing to evaluating, and then making normal, if you like, better practices. So the key component here would be bidirectional feedback loops, where you collect data that's often coming from care delivery. So this is something we haven't really been able to do in the past. So we do have the health administrative data, but they lack the detail and granularity of, say, frontline clinical encounters. In my own practice, for example, we capture things like patients' blood pressure when they come in, etc. And there's a whole lot of other things that you could analyze, but that are not currently easily collected. In a learning health system, you need to expand your data holdings such that you can get down to these granular data to understand patterns of care, needs for improvement, and also the impact of any changes. There's a need for a strong partnership between research and clinical operations. So I'm coming at this kind of from the academic research side, but I can't set up and operate a learning health system on my own. I would have to do this in conjunction with the provincial health authorities, the public, and the government, for example. The data infrastructure, meaning the capacity to capture the data, interpret it, and analyze effects, needs to be enhanced. So there's a certain amount of it within the academic environment. Some of the regional health authorities have, for example, a research arm that would be engaged with similar type of work. But if we were to broadly engage in learning health cycles, there would be a need for various people from frontline staff and managers to be able to interpret data and have access to the tools to analyze things within their own sphere, right up to high-level analytic capacity for, say, provincial jurisdictional questions. There would need to be then as well a knowledge mobilization methodology for taking new learnings and making sure that they are translated into care delivery. So if we try out something, say in Corner Brook on the west coast of Newfoundland, and it works, and that would be true, for example, of some of the new tools to help primary care physicians manage patients with diabetes, then if those work, then we need to scale them up so they become used in the province as a whole, and we educate the patients and providers about how to use those tools. We also need a way to identify new issues. So this can come from the public. I mean, I certainly had people from the, I'll call them patients of mine, complain about or make observations about aspects of our care that are not efficient or not effective, not patient-centered maybe. And those kinds of issues need a channel to be brought forward to decision-making to bridge the gap between issue identification and the starting of learning cycles. Now, you can't necessarily put all your resources to every question that comes up. So each entity that is part of a learning health system needs to have some kind of priority setting mechanism that will equitably assign resources to deal with the various issues that are identified. And then we need everybody educated on learning cycles so that their role is clear. For example, if you're a nurse on a ward, what is your role in a learning cycle? Well, it may be at the beginning identifying issues. It may be as part of a work group trying to design solutions or improvements in care processes. It may be in the implementation of the change. So we've had, for example, a campaign called Lose the Tube, which is aimed at the minimization of time post-operatively with catheters in the bladder. And clearly frontline staff are very important to this. They may have reasons to not take the catheter out because it changes their work process. They may have to look after people's toileting needs to a greater extent. But nevertheless, if they understand the importance, they will be part of the solution. And then, of course, understanding what works and how, and having patients and frontline workers be part of the knowledge spread system, such that they talk to their colleagues and say, well, I was doing it this way and this works better. That helps rather than just having directives coming down from above. So in part, that's development of a supportive culture, and learning health systems are generally developed both from the bottom up and the top down. So as we work with the leadership at the provincial and RHA level to enthusiastically encourage them to adopt this concept of a learning health system, they would then have to turn around and ensure that the culture within their workplace is aligned with that, and that staff aren't feeling disincentives or barriers when they wish to participate in the aspects of a learning health system. This is just an example here from the Swiss learning health system, which is a national entity, of the core components of their bridging mechanism. So this is how they go from issue identification through to spread and scale, and ultimately adoption of new processes. I'm not going to go through each of the elements, but you can see that there are resources required at different points, and that these are on the bottom there. So you have to have a stakeholder network. You need to have, for example, PhD scientists or a health information network. You need various people engaged in the dissemination of information and so on. So there's a clear role for patient partners in all of this. They help to ensure person-centeredness when we're designing new ways of doing business. They may be learners, enhancing their health literacy. They're obviously consumers of care, so they can provide feedback on the quality of that care and their experience with it. They may be sources of data. So in the process of receiving care and responding to it, the data collected as part of the health system will become important for understanding the need for new change. The patient partners will be collaborators in evidence generation and dissemination, as they are with the support unit now. And of course, they can be advocates for best care and outcomes. So keeping decision makers and policy makers feet to the fire, if you like, if there's an issue that hasn't been resolved. There's an ethical component to all of this, of course. There really is a moral imperative to continuously seek best practices and consistently apply them. And health equity may be advanced. Everybody can contribute to this kind of knowledge generation and may benefit from the lessons learned. So it's important to have this equity, diversity, and inclusiveness lens applied throughout to ensure that we are not leaving out components of the population where their needs are unmet or their voices unheard. Existing ethical review frameworks for research ethics may be too rigid for some of the ways in which learning health systems would evolve. For example, the Health Research Ethics Board here for the province will review research ethics, but they don't review quality improvement activities. And there is still a need for oversight of those kind of activities to ensure that they're appropriate. But at the same token, the rigid type of documentation and feedback processes required by the Research Ethics Board wouldn't necessarily make rapid learning cycles feasible. There needs to be, in a learning health system, a transparent contact between patients and the system so that people know and expect how their data is being collected and used. I think it's implicit right now that whenever you contact the health system, somebody's making a note about you, or there's data being collected within the system about your laboratory result or your imaging result. And those data are yours, not necessarily the physical data, but the knowledge of them. But at the same token, they are extremely valuable to people trying to improve the health system and health outcomes. And there needs to be an accountability mechanism then to ensure that best practices are implemented and to ensure that if they're not, that there's some means to address that. So here's just two examples of embedding knowledge generation in a health system. You can have observational studies and you can have experimental studies. So the observational studies would start with data from clinical care, which are analyzed for patterns and opportunities for improvement. We did a lot of that in phase 1 as part of quality of care's work. Then comparison to standards, either internal or external, for quality and adherence to best practice. So for example, when we use choosing wisely recommendations, they're to some extent the standard against which we're looking at current practices. The outcomes could include patient-reported experience and outcome measures. Now, these are sometimes available, but in a learning health system, you'd have to have a system to systematically capture these. So if you're looking at, for example, a population with irritable bowel or inflammatory bowel disease, that you have scales that allow people to report how well they're doing with their condition. And that analysis of these data on a say, collective basis could allow us to look at things like whether the usage of biological drug agents is effective, are people all accessing appropriate care who need it, and so on. And the effect of change is monitored, of course, in observational work is inherent in closing those cycles. Now, you might think it a little bit more difficult to do an experiment, but what we're really talking about here is things like randomized controlled trials in people. You can make these more efficient and embed them within healthcare by having target populations that you can identify in advance from so-called registries. So if we wanted to find everybody in the province with diabetes, for example, that can be done because there is a chronic disease registry developed by the Centre for Health Information that, using a variety of indicators, can say, yes, these are all the people with diabetes. Then you can do local pilot studies if you like. But once you've developed an idea that you think is going to be effective, you need to test that more broadly. And the type of trials that are done are usually pragmatic, often cluster randomized trials. Now, these are kind of researchy terms for those who aren't familiar with them. But a pragmatic trial would say we don't try to control every aspect of the population or the intervention that we're studying. We'll take a broad look at the people that might benefit. We're not limiting it to, say, people at highest risk or so on. And the intervention is loosely applied, so there's not really big focus on things like pill counts to ensure adherence to therapy and so on. The outcomes are often identified now from data sources such as the administrative data. So rather than having to develop an expensive way to keep track of what's happening to the people who had, say, coronary intervention, you simply go back to your database after a year or two and say, okay, let's pick out those that were in the different randomized groups and look at their outcomes. The studied practice is applied in general care. So rather than having a peculiar out-of-box type of trial intervention team, you would actually have the intervention being done in normal practice. And as I mentioned, then the outcomes collected as part of care. So that's how that was done in, for example, in the UK during COVID. They were much better positioned to actively test new COVID therapies without having to develop extensive research mechanisms, because they were able to embed that within their healthcare system. Now, I've mentioned this Health Accord NL earlier. So this was the 10-year process that we began in phase 1 of our funding, together with partners from the public and the healthcare delivery system, unions, government, and all sorts of other agencies that had an interest in health. It was co-led by my colleague, Dr. Patrick Parfrey, and Sister Elizabeth Davis, who's been a CEO of a health region in the past in the province. And they engaged a variety of work groups to look at things that are outlined on that circular diagram there, such as digital technology, the aging population, and the like. And they also had cross-cutting groups, which are mentioned in the top right corner. So they had an Indigenous advisory group, a community sector circle, key informant groups. These would be people like, say, the ambulance services, etc., who needed to provide input. And they had committees looking at governance, sustainability of the health workforce, funding and finances of health in the future. And a big part of what they looked at was the social determinants of health. So that was somewhat new in the sense that we need to try and build an alignment between what's done within the communities to enhance people's social well-being and the health outcomes that come from that. Because it's pretty clear that you get much more bang for your buck spending money on improving the social condition of people than providing advanced healthcare for advanced disease. So this is an example here of a health accord type of intervention aligned with a learning health system approach. So they're looking at a whole load of determinants of health, using data to identify what's currently working and what's not, combining input from various experts, system members, policymakers, and the public in understanding those patterns and in trying to devise best approaches to improvement. And then, having made these recommendations for change, we're now at the point of implementation. So I don't have a lot of feedback I can give yet in terms of the specific recommendations from the health accord. They're just beginning to get implemented. But community teams, for example, are being developed in many of the regions of the province as we speak. This will entail changing the way providers are paid, developing new communication tools for team interaction, and realigning the work of, say, community nurses with primary care, which is currently a little bit separate. So this will take us forward, I think, right through our phase 2. So the work we've done with developing the health accord actually provides us with a blueprint for the future. It's a massive priority setting exercise that widely engaged the public. There are fairly pervasive recommendations that would change a lot of how the health and social system work in the province. We will not be implementing it, obviously, as an academic group, but we will almost certainly be involved in the evaluation of the impact of change. And quality of care will also work on continuing to identify other priorities, keeping our lenses of equity, diversity and inclusiveness and value in place. We will need a strong patient voice on this, and I hope that we have that, and we'll continue to try and develop new patient partners as we go forward. And we will work closely with our providers and policy and decision makers to achieve the outcomes they desire. So that's all I have to say at the moment. We'll open it up, Amy, for questions, comments at this point.
Yes.
So I think I can probably stop sharing, so it gives us people a better chance to see the participants if they wish.
Are there any comments or questions? There was a comment in the chat box. I don't know if you had a chance to see that.
I didn't see it. Maybe you can share it with us.
Just says, thanks, Brennan. Excellent presentation. We'll follow up with you about diabetes related projects with DAC. Apologies. I have another meeting at 11. Catherine
Whiteside.
Yes.
Yeah, I saw her joining earlier. Yeah.
Yeah. Hi, Brendan. It's
Hi, Mike.
I put a question in the chat box, but I just sent it to you, actually. I just realized that.
Oh, okay.
Okay. Well, my question was, this past summer, the big announcement finally happened on SPOR 2. And what was the reaction, given that it was summer? I appreciate that. By researchers, folks in government, the public, or healthcare professionals. What kind of reaction did you get?
We got a bit of media attention. It was yeah. So some people shared it on social media. It was on the print media, television, radio, and stuff like that. I didn't get much direct feedback, but we have had people come to us and say, we're interested in working with you. They have ranged from, we had a meeting today, for example, with a PhD candidate who's from Bangladesh and working in anthropology, but would like to align their work with understanding the policy and decision-making processes around health accord. From the public, I think you'll probably be in a better position to judge that, Mike, as to what you thought of the announcement. I suspect generally it didn't make much difference to people, but through our community engagement work, we'll still try to stimulate some interest in our activities.
Yeah, it's one of those things that you got to keep it up, got to keep harping on it. That's a strong word, that this is out there, this is happening, and so the public sees that yes, there's value in this, and I'll be interested in participating, that kind of stuff, right?
Yeah, and we are planning some future town hall meetings now, because we were more or less stymied by COVID, so having in-person meetings became difficult. But I think a lot of people have become more familiar with and comfortable with the virtual meetings, and we're open to hybrid models. For example, our Share Summit this November will be both in person and online. That allows us to overcome geographic barriers too, so we can engage people in, say, Labrador who would no way travel to us, and we wouldn't really have the time or resources to travel there frequently either.
Thank you.
Any more questions or comments?
If there's not, I have another one.
Sure.
I guess over the last year, I've been hearing a lot, especially you've been the proponent of, I guess, health learning systems, learning health systems. One of the things that I guess concerns me is that they require, it's my understanding, lots of data, lots of information, and lots of people to, I guess, with that requirement is people to support it, and all those necessary links. Because even at the basic level, on a project I'm working on is a problem of accessing, what is it, patient data records, electronic data records, I think it's what it's called, whatever.
Yeah.
And what do you see there as some of the challenges and some of the solutions?
So yeah, thanks, Mike. I did mention that some primary data are captured but not accessible after the fact. And that can be for a variety of reasons. So in some places, they're still doing paper charts. No way you can get at that. If you're in primary care here in the province, the majority of physicians are using electronic medical records. And theoretically, one can access the back end of those through the Centre for Health Information and extract, I'll say, aggregate data. So we would never be looking at an individual patient, but we might want to understand the pattern of care for people who are identified as having depression, for example, and look at that broadly and see how do their providers interact with the mental health system. You know, what kind of resources are they providing to the patients for self-care as much as the formal healthcare system. The challenges there have really been that the system is not really set up for rapid access to the data, and the way in which notes are made is often non-uniform. So anything that's akin to a handwritten note, like something typed in using open language rather than specific codes, will be very hard to interpret. So we have a partnership with IBM, as you probably know, as part of the funding for our system. And we would work with them on natural language processing tools, for example, to try and enhance our ability to understand those kind of data. The other piece that might help in the longer term as well is the focus on digital health under the Health Accord process. So there's a strong recommendation there to enhance the health information systems and to ensure that they're interoperable, so that you no longer have silos whereby data in the hospital doesn't get shared with the community, data from community nursing doesn't get shared with primary care, and so on. Once we have such a system, one of the goals of designing that would be to have access to the data for learning cycles. So unlike Meditech, which is the current system in the hospitals, great for individual patient care. I can look back over years and see whatever was relevant to your chart, but I can't extract it across a program easily because there's no way to identify the people within that program. And the same way, I would find it very, very difficult to get all the primary data that we want because it's just not in there or it's inconsistently filed. So hopefully that'll be better in the future.
I think Amanda might have a question.
Sure. Amanda, you're on.
Sorry, I just have to unmute. To add to that, I'm curious about other data generators like dentists and physiotherapists and other health professionals in the community. How interconnected are they, and what's the plan for that to be brought in?
Very good question. They are not connected, right? So if you go to your dentist, they have a great information system for managing their practice, but other than if they needed to reach out to, say, a physician to ask a question about the use of a drug around the time of a dental procedure, they don't communicate with each other. We've been working with the Diabetes Action Canada on some projects to try and improve care for people with diabetes. And one aspect of that is eye screening. So looking at people's eyes on a regular basis to identify early aspects of diabetic change. It's very important. It does allow prevention of blindness. Now, much of the provincial provision of eye screening is actually not done by the formal healthcare system that's publicly funded, but it's done by optometrists. And again, they sit outside the system. They have their own charting ability, but there isn't a good communication pathway. So we've been engaged in discussions with government and have some upcoming meetings with them around how would we best develop and support such a thing as a provincial diabetic eye screening program. Who would be the participants and how would the data be flowing? If they chose to go with a model that incorporated the work of optometrists, then we would have to somehow allow them access to, for example, the electronic charts that might exist under a new digital infrastructure. I think you're muted. I'm not sure if you were saying something else.
That makes sense to me. I'm actually not in Newfoundland. I'm in Prince Edward Island.
Right.
And for example, I got diagnosed with dry eye disease lately, but it's paid for through the health network. So I don't know what our system is compared to yours. This was a wonderful presentation, actually, for me to wrap my head around what is going on in Newfoundland.
Sure.
Other questions I have is like some of the work that you're doing with Diabetes Action Canada, will that be transferable to other provinces since that's a national entity?
Yeah. I think the answer is yes. So they're hoping to work with us and with Quebec and Alberta at least, and they're primarily in Ontario. So all those 4 provinces would be trying to do something similar. The general goal we had was to look at integration of virtual care with in-person care for people with diabetes. But the notion coming from DAC was find the people at risk. So using data sources to identify the people with diabetes, which we can do, and then find the ones that maybe lack a family doctor or haven't had the appropriate screening tests done or healthcare interventions done for some time, which we can probably do, and then have some way to reach out to them and cross those gaps. So, you know, make the connections between the primary care level, the optometrists, the specialists in diabetes care, the foot care pathway, and all this kind of stuff. So having some way to integrate that uses our information systems effectively, that's kind of what they had in mind. You're still on mute.
Thank you.
Okay.
Mike, did you have another question?
Yeah, I had a question related to virtual care. You just touched on it then, Brendan. One of the things I've seen over the last year, I guess probably 2 years, driven, I guess, well, by COVID, is this whole, I guess, focus and priority on virtual care.
Yeah.
I sat in on a webinar about a week or 2 weeks ago. It was the one that was organized by the Globe and Mail on innovation in health. And it was amazing, the stuff that's going on. I never, ever thought was happening. This whole doctor in a box concept. And how, you know, through virtual care, what it's done. And you had a cardiologist talk about it. You know, she's using it, and she talks about the value in the north and that kind of stuff. Do you see virtual care as being a priority for SPOR 2 within Newfoundland, Labrador, or elsewhere?
Well, it won't necessarily be a priority on its own, but I think virtual care is here to stay. And as you mentioned, reaching remote communities, if they have broadband access in particular, can be valuable. Unfortunately, virtual care as it played out in this province during the pandemic was largely telephone care. And for many people that was inadequate or it didn't seem to meet their needs. There's a need to be careful in how you design your virtual care system. So at the minute, it was like, let's get this going rapidly. We need to replace in-person visits to family doctors with something else. So there was a fee code introduced. And for people who do fee-for-service practice, they then respond to that incentive. And it may be possible for them to do a more lucrative practice, doing a lot of virtual care, when in fact they probably should be seeing some of those patients in person. So we need to realign this such that virtual care is actually more inclusive. So it would allow us to interact visually like we're doing now, that it's booked appropriately, that it's logged. So some of the health information systems allow that to be done fairly easily. It's very difficult for me, for example, to set up a virtual clinic, to book patients, to ensure that they have access to a timed link, that it's secure, and that I can see their health information at the same time as I'm talking to them. But if you were using one of the electronic medical records, they have that capacity in many cases to electronically communicate with patients, agree on a booked time, provide that secure link such that the patient and provider are together at the same time, and go on from there. So I think it'll be important, but it's only one way of doing things, and it probably shouldn't substitute for in-person care in some cases.
I agree. Perfect. Thanks.
Any more questions or comments? No?
Amanda, you mentioned you're from PEI. If you have colleagues who want to have a look at this, the webinar will be available for you to share with anybody else.
I'm actually a patient partner, but my background is in research. So I actually had planned to share this. It's really informative. My first meeting as part of the HCRN advisory is Thursday.
Right, good, yeah.
I wasn't expecting it to be so beneficial as background and such, but it gives me a better picture of things that are going on, at least in Newfoundland. I did some training through CanChild and McMaster, the Family Engagement Research Program, and I'm starting another program there. So I've only known about patient engagement for 2 years. And when you talk about your community engagement model, my issue is ethically we should be engaging patients, caregivers, whatever, but many people don't even know this exists. The opportunities exist. So how do you get that out there?
Right, and that is one of the challenges for a learning health system, to ensure that everybody knows about it and has an opportunity to contribute.
Sorry to interrupt. The other thing about a learning health system, we have such a model that the doctor's going to fix us, that we're not looking at all of those other community things that can promote well-being before that end stage.
Yeah.
So how do you get people on board with that without that engagement piece first?
Yeah, no, I think we did a lot of engagement as part of Health Accord NL development of recommendations. So there were like thousands of interactions with the public and interested parties. And the focus on the upstream social systems and well-being is there. You know, that's relatively new to, say, the Department of Health, because now they're having to talk to folk in education and justice and so on. And we're trying to co-develop ways to interrogate data and look at integrating it in a way that you can say, well, if I make this kind of health policy choice, it has a detrimental impact on crime rates or people's food security or something like that. So we're trying to get them to think more broadly and make sure that there's a health in all as one of their policy statements. So if you choose to do something around, say, supporting people through challenges with the cost of living, to make sure it's effective, that you reach the people who really need it, and that it does improve their health, you know, so being able to close that loop would be good.
And collecting the data is really important to do that, though, because we make policy decisions without collecting the appropriate data.
Yeah.
And then we don't have the data to support or the policy. So the policy gets, or the practice gets left behind. So I know Newfoundland may be further ahead than we are. Anyway, I digress. I have to go, and thank you for entertaining my questions. They're very
Sure, great.
What you're doing is awesome. There are several people that I plan to forward the link to when the video is available.
Thank you very much.
Yeah.
And thank you, Mike, too, for your contribution.
And thank
Always
you,
helpful.
Dr. Barrett. Okay, so we're all good.
Yeah, I guess so.
Okay, thank you.
Thanks again.
Thanks,
See ya.
everybody. Bye.
Bye.